Now let's think about some of those secondary immunodeficiency conditions. The most notable form of acquired immune deficiency was caused by an infection is acquired immunodeficiency syndrome, also known as AIDS. It is caused by the human immunodeficiency virus, HIV, which infects CD4 helper T cells. This lack of an effective number of helper T cells makes individuals susceptible to many life-threatening infections. The HIV virus is a retrovirus. This means that it carries its genetic information in RNA rather than DNA. It is capable of lying dormant for a long time. The HIV-1 is the form most common in the United States, Europe, and Central Africa. The HIV virus infects CD4 T lymphocytes, also known as helper T cells. I'm assuming that you know the function of helper T cells. When an HIV replicates, it kills the CD4 T cell that contains the virus and releases copies of the virus into the bloodstream. These particles invade other helper T cells. The helper T cell count will gradually decrease, and as this happens, the immune system becomes less and less effective. For a long period of time, the infected person may be asymptomatic. They can be tested by looking for HIV antibodies in the blood. These antibodies, while present, are unable to deactivate the virus. In 1981, the CDC reported an unusual disease that they called GRID, gay-related immune deficiency disease. This happened because they were seeing an unusually large number of cases of a form of pneumonia which only occurs in those who have a compromised immune system. At the same time, they were also getting reports of large numbers of cases of Kaposi sarcoma, a rare form of skin cancer, again found only in those who have an impaired immune system. In 1982, they started to see an increase in the number of people having this condition among the hemophiliac population, and at that time they started using the name AIDS. Prior to 1985, when we started testing the blood supply, 80% of the people who had hemophilia became infected with AIDS because they were getting it through their clotting factors that were being taken from whole blood. AIDS has been around for quite a while, but in just small numbers of cases. Because it was only occurred in isolated instances, not much attention was paid to the first cases, and it wasn't until 1981 that the United States Center for Disease Control began to think there was some new disease out here they needed to be looking at. The populations who are most infected include homosexual men, who account for just over 50% of all infections and almost half of the deaths. African Americans, who even though they only make up 14% of the population, account for approximately 44% of the new infections. Hispanics, who make up 16% of the population, but account for 21% of the new infections in 2010. Women account for about 20% of the new infections in 2010. How fast AIDS progresses varies greatly from person to person. Without treatment, most people will progress to full-blown AIDS within 7 to 10 years. This group of individuals is known as typical progressors. About 10 to 20% of those infected will be rapid progressors, meaning that they will develop AIDS within 2 to 3 years. About 5 to 15% of those affected will be slow or long-term progressors who will not develop AIDS for at least 10 years or more. Within these slow progressors, there are some persons who have very low levels of the virus and who have lived many more than the 10 years since their infection. Magic Johnson, for example, the former NBA star, was diagnosed in 1991 and apparently has still not progressed to full-blown AIDS. AIDS infection follows a typical course of infection that is spread over several years. During the primary phase, the person has symptoms similar to mononucleosis: fever, fatigue, sore throat, night sweats, gastrointestinal problems, headaches, and rash. Of these, malaise and fever are the most common. These signs and symptoms usually appear 1 to 4 weeks after infection and last from 7 to 10 days. If AIDS is diagnosed during this phase, it is far easier to control the replication of the virus and thus possibly prolong the time before the overt phase is reached. The second stage is the latent period. There are no signs or symptoms. The length of time this stage lasts varies, but the average time is about 10 years. Some people will have swollen lymph nodes during this period. The third stage of overt AIDS occurs when a person's CD4 T cell count has dropped to less than 200 cells per microliter, or the person has an AIDS-defining illness. Without treatment, death usually follows within 2 or 3 years, but there's a lot of variation in that time frame. People usually do not die from AIDS. They die from opportunistic infections, cancers, and organs failure due to a failed immune system. Masks and gloves are worn to protect the patient from the healthcare professional, not the other way around. Here are some infections and cancers that are commonly seen in AIDS patients. Pneumocystis jirovecii is a form of pneumonia caused by bacteria. This type of bacteria usually does not infect people with normally functioning immune systems. Tuberculosis is the leading cause of death worldwide in people with HIV. There had been a decrease in tuberculosis in the United States until 1985. After that, the number of cases increased every year. Often, the first manifestation of HIV infection is the development of a yeast infection. Toxoplasmosis is caused by a protozoan, and it affects the nervous system. Some of the symptoms will include fever, headaches, confusion, lethargy, visual disturbances, and seizures. A person can get toxoplasmosis from eating undercooked meat and from contact with cat feces. Cats carry this organism, so do not empty the litter box if you're pregnant. Progressive multifocal leukoencephalopathy is the disease known as PML, is a disease that attacks the myelin in the brain. The result is progressive limb weakness, visual problems, and trouble controlling the digits. This will progress to alternations in mental status and seizures. There is a very high mortality rate with this condition. Wasting syndrome has become an AIDS-defining condition. It involves involuntary weight loss, diarrhea, chronic weakness, and fever. Non-Hodgkin lymphoma is showing up in increased numbers among people with AIDS. Again, this is probably due to the reduced vigilance of the immune system. This is just for your information. I'm not going to test you over the material on this slide. Kaposi sarcoma is a malignancy of endothelial cells that line small blood vessels. It was one of the first opportunistic cancers associated with HIV infection. It has also been linked to the herpes 8 virus. People with the condition have large circular red or violet lesions on their skin, also in their mouth, their lungs, and their gastrointestinal tract. This is a cancer normally not seen in the general population who have a normal immune system. Kaposi sarcoma is a malignancy of endothelial cells that line small blood vessels. It is one of the first opportunistic cancers associated with HIV infection. It has been linked to the herpes virus 8. People with the condition have large circular red or violet lesions on the skin, also in their mouth, lungs, and gastrointestinal tract. This is a cancer normally not seen in the general population who have a normal immune system. Hypersensitivity is when inappropriate responses are made by the immune system. As mentioned before, immune responses can be both beneficial and detrimental. There are several inappropriate responses that our immune system can make. These include an exaggerated response to an environmental antigen. We often use the term allergy to describe such a reaction. Allergy originally meant both sides of the immune response, immunity which is beneficial and hypersensitivity which is harmful. It has come to mean just the harmful portion, hypersensitivity. Autoimmunity is when we start attacking our own antigens. An alloimmune disease is when we have a reaction against someone else's tissues. This could include a reaction to a transfusion or to the fetus during pregnancy. Immune deficiency occurs when there is an insufficient response by our immune system to an antigen. Let's consider what happens when the immune system reacts to environmental antigens in a harmful manner. The mechanisms of hypersensitivity which result in disease have been divided into 4 distinct types of reactions. You will need to know these 4 different types of hypersensitivity, what is involved, and some examples of each type. Type 1, or immunoglobulin E-mediated hypersensitivity, causes most common allergic or anaphylactic reactions. These reactions range from annoying, a runny nose, to life-threatening anaphylaxis. Exposure to an antigen causes helper T cells to release cytokines that stimulate B cells to release immunoglobulin E antibodies, which bind to the crystalline fragment receptors on the surface of mast cells. It often takes repeated exposure to fairly large doses of the antigen or allergen to get enough of the immunoglobulin E for the person to be sensitized. After further exposure, the antigen will bind to 2 of the antibody molecules on the mast cell surface. This causes the mast cell to break down and release several chemicals which will bring about the allergic or anaphylactic response. Mast cells are typically found in connective tissue under the skin and under the mucous membranes of the respiratory system. They are also found near blood and lymph vessels. Here are some of the chemicals released by the breakdown of mast cells. Histamine causes vasodilation and increased permeability of capillaries and the formation of exudate. This causes edema. Histamine also constricts smooth muscles into the bronchi and attracts the eosinophils to the area. It causes an increase in gastric acid secretion, which can result in vomiting, diarrhea, and abdominal pain. Neutrophil chemotactic factor attracts neutrophils to the area where they will do phagocytosis. Eosinophil chemotactic factor attracts the eosinophils to the area. They will also do phagocytosis. This can be beneficial if the host is infected with parasitic worms, which eosinophils will attack. Prostaglandins and leukotrienes are secondary mediators which contribute to the inflammatory response. We usually get the primary response after 5 to 30 minutes, the secondary response within 2 to 8 hours. This can last for days. The systemic reaction known as anaphylaxis is a life-threatening reaction to an antigen. The severity of the reaction depends upon how sensitized a person is to a substance. Some of the common allergens are peanuts, tree nuts, shellfish, and insect stings. Within minutes following exposure, a person will develop itching and hives, followed by bronchospasms and respiratory distress, vomiting, abdominal cramps, and laryngeal edema. Without treatment, the person may go into shock and die. The 2 main priorities in treatment are the need to administer epinephrine and to establish an airway. Avoidance of the allergen is the best policy. Local reactions usually occur when the antigen is confined to a small portion of our body. These reactions include urticaria, allergic rhinitis, dermatitis, food allergies, and some forms of asthma. This is a picture of a person with urticaria or hives. This is a dermal manifestation of an allergic reaction. It is caused by histamines and increased vascular permeability, resulting in limited areas of edema. White, fluid-filled blisters, called wheals, are surrounded by areas of redness, called flares. Urticaria is usually accompanied by itching. It can also be caused by other things besides hypersensitivity. These include stress, medications, and exposure to cold. Often, the autonomic nervous system is the best controller of type 1 reactions. It produces epinephrine, which blocks histamine receptors and thus controls the inflammatory response. This does more good than antihistamines because histamines have already bound to the receptors. Immediate injections of epinephrine can reverse the effects of histamine. Type 1 responses are a systemic response to an allergen. Some examples include allergic rhinitis, where there is swelling of nasal mucosa and sneezing. It is often the result of exposure to ragweed, grasses, trees, dust mites, animal dander, and feathers. Asthma is a life-threatening condition which involves laryngeal edema, which leads to choking, or bronchial spasms, which lead to wheezing, or vasodilation, which may cause pulmonary edema and circulatory failure. These symptoms come about as a result of a massive release of histamine. The best treatment for asthma is the use of epinephrine and bronchodilators. With food allergies, the immune system attacks tissues in the skin, gastrointestinal, and respiratory systems. Anaphylactic shock is a system-wide reaction which can be life-threatening. There is some genetic disposition to allergies. If one parent has allergies, there is a 40% chance of the offspring developing allergies. The chances of developing an allergy are 80% if both parents have allergies. Type 2 hypersensitivity antibody-mediated reactions occur when a specific cell or tissue is the target of an immune response. The target cell is usually destroyed by an antibody working against an antigen on the cell membrane. This would be beneficial if the target cell is a bacterium. Immunoglobulin G or immunoglobulin M antibodies are usually involved in this type of hypersensitivity. There are several kinds of mechanisms that will be discussed on the next slides. One mechanism of type 2 hypersensitivity is the activation of complement. The complement damages the membrane and the cell lyses or dies, or agglutination occurs. This is what happens to red blood cells with a mismatched transfusion. A second mechanism is when complement causes opsonization, and then phagocytosis can occur. Here we see cell lysis as the result of complement attaching to the membrane and damaging the cell membrane. As a result of damage to the cell membrane, the cell dies. This is what happens when we're given a transfusion of the wrong blood type. It is also a problem with Rh incompatibility. The target cell is coated with complement, and this makes it easier for a macrophage to engulf it. The crystalline fragment end of the antibody is attached to the macrophage's receptors. This is what happens to the infant's blood cells in erythroblastosis fetalis. A third mechanism is that the immunoglobulin G antibody will attach to the target cell, and the natural killer cells will bind to the crystalline fragment receptors on the target cell. Here you see that happening. The antibodies have attached to the target cell, and the natural killer cells are attaching to the crystalline fragment at the end of the antibody. Normal cells usually have class 1 MHC molecules that are recognized by the natural killer cell's inhibitory receptors. Abnormal cells lack these MHC molecules, so when the natural killer cell attaches to them, there is nothing to keep the natural killer cell from destroying the cell. A fourth mechanism of type 2 hypersensitivity is when antibodies are blocking receptors on the target cells. In myasthenia gravis, antibodies block the acetylene receptors. This impairs neuromuscular transmission and causes muscle weakness. In Graves' disease, antibodies activate the thyroid-stimulating hormone receptors on thyroid cells, and this causes the overproduction of thyroxine and sometimes the enlargement of the thyroid gland itself. Another example of type 2 hypersensitivity is hematolytic disease of the newborn, also known as erythroblastosis fetalis. With this reaction, maternal antibodies will destroy the fetus's erythrocyte. This response can be prevented with the administration of RhoGAM, an injection which destroys the maternal antibodies. An injection of RhoGAM is usually given to the Rh-negative woman at 28 weeks during pregnancy and again after delivery. There will be a buildup of bilirubin in the fetus if lots of erythrocytes are destroyed. This bilirubin will accumulate in the brain and cause cerebral damage. These next slides show how erythroblastosis fetalis develops. First, there is a leak in the blood vessels within the placenta, and fetal erythrocytes enter the maternal circulation. The mother's body will manufacture anti-Rh antibodies. Second, we see the mother's body manufacturing the anti-Rh antibodies. Third, the anti-Rh antibodies cross the placenta and attach to the fetal erythrocytes, causing them to clump or agglutinate. Some of the problems which may occur from this include severe anemia due to the loss of erythrocytes, compensatory hyperplasia of hematopoietic organs, jaundice as a result of the accumulation of bilirubin, and possibly brain damage from all of this surplus bilirubin. Most type 3 hypersensitivity is the result of antigen-antibody complexes, which are formed in the circulation and deposited later in vessel walls or other tissues. In type 2 hypersensitivity, the antibody binds to an antigen on the cell surface. In type 3, the antibody binds to a soluble antigen, which was released into the blood or body fluids. The harmful effect of this deposition comes from the complement activation that occurs as a result of inflammation and through the generation of chemotactic factors for neutrophils. The neutrophils arrive and attempt to ingest the antigen-antibody complex. They release large quantities of lysosomal enzymes, which will damage the tissue where the complex was deposited. The process commonly damages blood vessels and joints. Here we see an antigen-antibody complex being formed and being deposited on the wall of a blood vessel. In the bottom of the picture, a neutrophil is releasing chemicals that are destroying the wall of the blood vessel. Systemic lupus erythematosus is a chronic widespread inflammatory disease that affects almost all of our systems. Its cause is unknown, but it seems to be the result of the failure of the body to destroy self-reactive B cells. These self-reactive B cells form antibodies which will directly damage tissues or form antibody-antigen complexes in organs that interfere with their normal function. It is a disease which is characterized by periods of exacerbation and remission. Joint pain is a common early symptom of the disease. The treatment of lupus focuses on managing the acute and chronic symptoms of the disease, reducing exacerbations, and minimizing disability and preventing complications from medications. Lupus can be controlled but not cured. It occurs more frequently in young women and is most common among African Americans, Hispanics, and Asians. There seems to be some genetic factors involved with its development. Environmental factors are thought to play a role in triggering the development of the disease. These possible triggers include ultraviolet light, chemicals, infectious agents, and some foods. Skin manifestations vary greatly, but the acute skin lesions include the classic butterfly rash on the cheeks and the nose. Hair loss is common, as is sun sensitivity. Another example of type 3 hypersensitivity is serum sickness, which often is caused by intravenous administration of drugs such as penicillin or by insect venom or food allergies. With this condition, antibody-antigen complexes are deposited in various tissues such as blood vessels, joints, and kidneys. Arthritis reaction is a term used to describe a localized tissue necrosis, usually in the skin, caused by immune complexes. This type of reaction is often seen with certain medicines or drugs. A drug combines with an antibody and causes inflammation of a blood vessel. This sometimes occurs after vaccinations for diphtheria or tetanus. Arthritis reactions are characterized by severe pain, swelling, edema, hemorrhage, and occasionally by necrosis. The first three types of hypersensitivity are all mediated by antibodies. The type 4 reactions are mediated by T lymphocytes. They often occur as the result of the actions of cytotoxic T cells or lymphokine-producing helper T cells. Cytotoxic T cells attack and destroy cells directly. Helper T cells produce cytokines which attract and activate phagocytic cells. Examples of type 4 reactions include transplant rejections, the skin test for tuberculosis, where the site is infiltrated with T cells and macrophages, and as a result of this we get a clear hard center and reddish areas surrounding the center. And allergic reactions resulting from contact with substances such as poison ivy and metals. Also, there is a type 4 component to many autoimmune diseases. In rheumatoid arthritis, T cells attack collagen, a fiber found in the joint. In diabetes, the T cells attack an antigen on the surface of the pancreatic beta cells. Allergic contact dermatitis involves a hapten, a molecule too small to be reactive by itself. The hapten binds to a protein in the skin or to another protein somewhere in the body. This is an example of delayed hypersensitivity. Catechol molecules from poison ivy plant combine with the skin protein. Usually, there is no problem with the original contact, but T memory cells are created. On secondary contact, a cell-mediated reaction occurs that causes dermatitis. Other substances that may cause contact dermatitis include hair dyes, cosmetics, some metals, and latex. Autoimmune diseases occur when we stop tolerating our own tissues and begin to recognize them as foreign. Normally, during embryonic development, autoreactive lymphocytes are either eliminated or suppressed. Clones of cells with antigen receptors for self-antigens are deleted. There are several theories about how this happens, and they will be discussed on the next slide. There are several ways that autoimmune diseases can develop. I would know them. The first involves sequestered antigens. Normally, self-antigens are exposed to the developing fetal immune system. Sometimes this contact is not made, and we refer to that as sequestered antigens. This is especially possible in the cornea of the eye and in the testicles, as neither is drained by the lymphatics, and they actively suppress the function of any T lymphocyte that might enter the tissue. Self-antigens in these sites are not normally seen by the immune system, and therefore are not immunogenic. However, following trauma, the antigens may be exposed. Physical trauma to one eye may result in the release of a sequestered antigen, which will result in immunologic injury to the other eye. This is called sympathetic uveitis. In molecular mimicry, the body reacts to a foreign antigen which is quite similar to one of its own proteins. The antibodies or T cells produced may recognize the self-antigen as foreign. An example of this is the bacteria that causes rheumatic fever is very similar to self-antigens on the heart valves. This does not happen to everyone who gets rheumatic fever. It depends partially on the MHC proteins, but some people who get rheumatic fever, following the course of the disease, the body will attack those antigens on the heart valves. With the neoantigen, a new antigen is introduced that may be a hapten, which becomes immunogenic after binding to host proteins. The reaction to the neoantigen may lead to an immunologic reaction against an unaltered host protein. Or, this may be the result of some kind of trauma, which causes the formation of new proteins. This could be an injury or a viral infection. Poor sorting of lymphocytes happens when autoreactive cells are not destroyed during fetal development. As a result, they persist and may later attack some of our own tissues. In myasthenia gravis, receptors for acetylcholine on muscle cells are destroyed. This impairs the transmission of the nerve impulse at the neuromuscular junction. Eye muscles and those controlling movement of eyelids are those most commonly affected. Muscle weakness will progress to respiratory muscles, chewing and swallowing will be affected. Eventually, limb movement will be affected.